Assalamualaikum and good day everyone. Today we'll be presenting a case study on one of Malaysia's deadliest methanol poisoning outbreaks which took place in September 2018. The incident mainly affected areas like Kuala Lumpur, Selangor, Klang Valley and Hulu Langat, leading to at least 45 reported deaths and over 100 hospitalizations. Most of the victims were foreign workers from countries such as Bangladesh, Nepal, Myanmar and India, although a few Malaysians were also affected. The outbreak was traced to the consumption of counterfeit alcohol beverages containing dangerously high levels of methanol, a toxic chemical commonly used in industrial products. Methanol is not safe for consumption. When ingested, it is converted in the body to formic acid, which can cause severe metabolic acidosis, permanent blindness, organ failure, and even death. The wide circulation of these fake products was largely driven by Malaysia's high alcohol taxes, which led many low-income individuals to seek cheaper illegal alternatives. The first suspected cases appeared on 14 September 2018 in Semenyih, Hulu Langat, Selangor. Victims, mostly foreign workers, began experiencing symptoms like vision loss, vomiting and stomach pain about 2 days after drinking illicit liquor. The next day, on 15 September, the first fatality was reported. 2 more patients were admitted to Selayang Hospital and methanol poisoning was suspected. Then, on 16 September, the Hulu Langat District Health Office started receiving more alerts, especially from Kajang and Ampang hospitals. That same day, a methanol outbreak was officially declared, and a rapid response team was activated to begin epidemiological investigations. From 16 to 24 September, this was considered the main exposure period, where most victims had consumed the toxic alcohol. On 16 September alone, the outbreak reached its peak, with about 25 new cases reported just in Hulu Langat. After that, throughout September and October, the outbreak continued to spread, with 98 reported cases in Selangor, Kuala Lumpur, Putrajaya, Perak and Negeri Sembilan. Unfortunately, at least 45 people died from methanol poisoning during this time. In response, the Ministry of Health and enforcement agencies carried out major operations. They confiscated over 50,600 bottles of suspected fake liquor from nearly 2,000 premises and arrested about 30 individuals involved in the sale and distribution of these illegal drinks. As a result of the event, a wide range of interventions was implemented. This included active case detection, multilingual public education, health checks, and law enforcement raids to stop the spread of the outbreak. By 35 September 2018, the outbreak period was considered to have ended and the Outbreak Coordination Centre in Hulu Langat was officially closed. This case stands out due to several unique aspects. Firstly, it represented a public health crisis rather than an isolated incident, as a large number of people were affected in a short period. Secondly, it exposed deep-rooted socio-economic issues, since the victims were primarily low-income migrant workers with limited access to regulated alcohol. Thirdly, the incident highlighted serious enforcement weaknesses in Malaysia's food safety and alcohol laws, especially under the Food Act 1983 and the Excise Act 1976. Besides, authorities discovered large quantities of unlicensed alcohol containing methanol at levels far exceeding safe limits. Several arrests were made, including suppliers and retailers. In response, national raids and inspections were launched, and the tragedy sparked calls for stricter alcohol regulation, greater supply chain transparency, and better protection for vulnerable communities. Despite these efforts, numerous problems were identified in how the situation was managed. The most critical issue was regulatory failure because the counterfeit alcohol was being produced and distributed with minimal monitoring. The healthcare system was also not well prepared. There were delays in diagnosis, a shortage of the expensive antidote fomepizole, limited ICU capacity, and inadequate dialysis facilities. Next, language barriers between medical staff and non-Malaysian patients made it difficult to assess and treat symptoms quickly. Furthermore, existing consumer protection laws did little to help the foreign victims, so many of them were unaware of their rights or how to seek legal help. Lastly, public warnings were issued too late and were not tailored to the multilingual population, reducing their impact on the at-risk migrant community.
Today, I'll be presenting a critical assessment of the 2018 methanol poisoning outbreak that occurred in Hulu Langat, Malaysia. This case is not just a toxicological tragedy, it's a reflection of systemic gaps in regulation, healthcare access, and public health preparedness. Let's start with how methanol causes harm. Victims consume illegal alcohol containing methanol. Blood tests show that concentration as high as 1,200 mg per liter, far beyond the 500 mg per liter threshold considered fatal in toxicology literature. Biochemically, methanol is converted in the liver to formaldehyde and then to formic acid. This acid builds up leads to metabolic acidosis, optic nerve injury, and brain toxicity. Symptoms like vomiting, blurred vision, and coma appear quickly within 30 to 90 minutes, consistent with the established toxicokinetics. According to Breslows and the World Health Organization data, the observed effects and mortality directly match nose puffers and thresholds of vulnerability. Who were the victims? The all confirmed cases were migrant men, mostly laborers from Bangladesh, Nepal, and India, aged from 21 to 48. They bought illegal alcohol from nearby vendors. Barriers like poverty, language, and undocumented status prevented them from accessing a safe alcohol or understanding poisoning symptoms. This is not new. The World Health Organization and global studies have shown that low-income migrant workers face higher risk. Malaysia's own 2013 outbreak involved the same groups, proving that this vulnerability is systemic and not accidental. The third critical assessment is forensic and clinical system tests. Once symptoms appear, many patients face delays. Methanol tests could only be done at centralized labs, and most victims arrive late. Some have already unconscious. The antidote, ethanol or fomopizole, were not always available at local hospitals. Worse, many frontline healthcare workers were not trained to suspect or treat a methanol poisoning. A 2020 paper in the Journal of Forensic and Legal Medicine confirmed these issues across Malaysia. The systemic gaps in readiness clearly worsened the outcomes. The last critical assessment is the legal and regulatory weaknesses. Malaysia does have laws under the Food and Poison Acts to prevent an illegal alcohol production, but before the outbreak, enforcement was minimal. Only after the dozens were hospitalized did the authorities raid 150 outlets and seize alcohol with methanol level as high as 1,700 milligrams per liter. Research into outbreak prevention emphasizes that enforcement needs to be proactive and routine. This case shows that waiting until tragedy strikes is too late. Now let's move on to possible solutions that could have prevented or minimized the damage of the Hulu Langat methanol poisoning outbreak. We brainstormed a range of realistic evidence-supported options in which each targeting specific weaknesses in the system. The first alternative action is to have a multilingual awareness campaigns. The victims in this outbreak were all migrant workers. Many likely did not understand official Malay or English health warnings. Running a public health campaigns in Bengali, Tamil, Hindi, and Nepali could have saved lives. This strategy has already proven effective in World Health Organization initiatives across Southeast Asia. The pros is that it reaches at-risk groups faster and ensures inclusivity. The cons, it requires strong coordination with interpreters, NGOs, and community leaders. The second alternative action is to have routine alcohol surveillance. Another solution is routine alcohol testing using methods like FTIR or GCMS to detect methanol in suspicious groups before people consume them. The pros is that this can catch tainted alcohol early and prevent mass poisonings. The cons is that, however, it requires lab capacity, expensive equipment, and skill analysis, especially for a location that is challenged in under-rural or under-resources areas. The third action is to have emergency antidote stockpiles. In this outbreak, many hospitals lack of access to life-saving antidotes like ethanol or fomopizole. The pros is that if regional hospitals had emergency stockpiles, death and blindness could have reduced significantly. The cons is that it also needs a proper cold chain system and hospital staff trained to administer these antidotes promptly. The fourth alternative action is that the licensing low-cost safe alcohol. Some countries like India and Indonesia have reduced methanol-related death by licensing affordable diet alcohols as a safer alternative to bootleg brews. This pros is that it reduces demand for illicit and unsafe alcohol. But in Malaysia, this solution is politically sensitive and would require major law reform to implement safely and ethically. The last alternative action is for toxicology training for frontliners. Finally, toxicology training for emergency room staff is critical. Many ER doctors miss early signs of methanol poisoning, leading to treatment delays. The pros is that training will improve faster symptom recognition, allowing treatment to begin even before lab results is taken. But the cons is that rolling this out nationwide will take time and resources, especially in less developed hospital systems. The conclusion is that, as you can see, each of the solutions has both benefits and limitations, but together they offer a much stronger, proactive public health response and could drastically reduce fatalities in any future methanol-related outbreak.
From all the alternative actions that were recommended by Kasih, 2 have been selected for implementation based on their feasibility, impact, and sustainability. These are multilingual awareness campaigns and emergency antidote stockpiles and frontliner training.
Our first recommendation is to implement multilingual awareness campaigns targeting foreign workers who were the most affected group in the 2018 maternal outbreak. A major issue was the language barrier, which led to delays in seeking medical help. We propose to develop educational materials on maternal poisoning, including symptoms, emergency responses, and legal rights, and translate them into Bengali, Tamil, Nepali, and Hindi. These materials will be distributed through foreign worker dormitories, social media groups, and local NGOs, ensuring better access to crucial health information. Moreover, we plan to coordinate with employers and embassies to incorporate safety training during worker onboarding. The effectiveness of this campaign will be monitored via community feedback and tracking poisoning incidence rates. Our second recommendation addresses the critical need for emergency antidote stockpiles and frontliner training. The 2018 outbreak showed that delayed recognition and treatment were major contributors to the high mortality rate. We recommend conducting a national stock audit of ethanol and fomepizole availability in public hospitals. These antidotes should then be distributed to regional and district hospitals based on high-risk zone. We also propose partnership with forensic toxicologists to design crash course modules for ER doctors and paramedics to help them identify maternal toxicity symptoms such as blurred vision and acidosis. To ensure readiness, response drills should be stimulated every 6 months. Additionally, antidote request protocols must be created to allow hospitals to quickly replenish stocks.
To conclude our presentation, the 2018 maternal poisoning outbreak in Hulu Langat was a serious public health emergency that revealed many weaknesses across our healthcare, social, and legal system. Within just 10 days, 25 suspected cases were reported. Of these, 12 were confirmed maternal poisoning and 6 people died. All the victims were foreign male workers aged between 21 to 48 years old. Blood tests shows that maternal level as high as 1,200 mg per liter, which is several times higher than the toxic threshold. Victims experienced symptoms like vomiting, blurred vision, and unconsciousness after just hours after consuming their alcohol. Unfortunately, many of them arrived at the hospital too late to receive life-saving treatment. From the toxicological aspect, methanol is converted in the body to formic acid, which lead to optic nerve damage, metabolic acidosis, and eventually death. But this outbreak was not just about chemistry. It exposed deep system failure. The victim had no access to licensed alcohol, no education in their language, and no idea what symptoms to look out for. Most of them were afraid to seek for help. This healthcare system was also not prepared. Hospitals did not have on-site toxicology testing. Antidote like ethanol or fomepizole were not always available, and many frontliners lacked training to recognize the symptom of maternal poisoning. On the enforcement side, action only came after people had already died. Authorities raided over 150 illegal alcohol vendors, and some of the sales liquor contained almost 200,000 milligrams of methanol per liter, which is hundreds of times above the safe limit. In response to this issue, our team proposed 2 key recommendations. First, multilingual awareness campaign to improve health education among foreign workers. Second, antidote stockpile and training program to ensure our hospitals are always ready and respond quickly and effectively. This outbreak shows us that toxicology is not just about identifying dangerous substances. It is about identifying the system failure that allows those substances to cause harm. Without proactive education, strong enforcement, and better hospital readiness, even a preventable chemical like methanol can become deadly. Moving forward, we must invest in inclusive communication, improve frontline capacity, and shift our approach from reactive to preventive. Only then we can protect every community, especially the most vulnerable. That's all from us. Thank you.